It's with great pleasure that I will be introducing Dr. Zubir Ahmed to the stage in a moment. Zubir is a Scottish Labour Party politician and a surgeon. I don't know why people laugh at that. And he's been serving as an MP for Glasgow South since the last election. Shortly after his election, he had the tap on the shoulder and was appointed as Parliamentary Private Secretary to the Health Secretary Wes Streeting. Zubir is known for his pragmatic approach to politics. You can tell he's not been elected long. Influenced by his background in surgery, transplant and vascular, I think, yep, where evidence-based practices are crucial. But in the meantime, let me please hand over to Zubir Ahmed.
Thank you very much, and in the spirit of continuity, I literally am a bloody surgeon. And happy to be one. And what I thought I would do here, because I'm in front of quite a learned audience, which is unusual these days, because I talk to a bunch of stakeholders who don't necessarily know in depth about healthcare, is talk about what I think is the importance of having someone with some knowledge about the health service in government, share with you some of my frustrations when I used to work full-time as a clinician, and then how we're translating that into action in government with a 10-year plan, and really how we're trying to reset the relationship with technology in the round, but also those that deliver that technology. So I basically studied and trained in Glasgow. I did my fellowship in transplantation in London. I trained in Canada. I've worked in every nation of the UK as a clinician, so I do feel like I have a fairly well-rounded experience as to what's going on. I've been in medicine for 20 years, and as you know, with clinicians and particularly bloody surgeons, we moan quite a lot. And when I first started in surgery in the sort of noughties, when there was a Labour government, we still moaned. But in retrospect, it was bloody good. Like, I mean, it was joyful to go to your work. And for the last 5 or 6 years, I personally can't say it's been like that. And that's been one of my own motivations to do something differently. Because as a clinician, as a surgeon, as anyone that works in the health service, by and large, when you're making decisions, it's from the point of view of a patient or a small group of patients. But truly in politics and with the privilege of government, you do have the opportunity to make life-changing strides for hundreds of thousands of millions of patients. That was my own personal motivation to get into this space, to marry some of my experience, my knowledge, with the policy that's come from the party. And then most importantly, of course, and the most difficult part of it is the delivery, as we all know. So what have we been doing since we've been in government? You'll have noticed that most of the headline news of the delivery components of government have come, I'm glad to say, from the Department of Health and Social Care. And that's because we are trying to do something quite unique. We're trying to speed up the supertanker that is the National Health Service, or the Department of Health and Social Care, which, remember, consumes 44% of government spending, and also then to turn it around. And what's really heartening in that process is people like yourselves and everyone else that works in the health service wants to partner with us and to co-create the next step and the next iteration of this health service. And that was quite different to, I think, the situation we had back in 1997, 2001, where I think government did rub up against a lot of vested interest, particularly from clinicians. But my conversations with clinicians in particular is that they want and are rich and richly kind of have a rich appetite for that creative destruction that we need to see to reset things. Obviously, you guys in the room, the non-clinicians that are in businesses that deliver health improvement, health technology, have kind of always been in that space because it's in your DNA. And that's why I like spending time with you, because it genuinely motivates me to hear your stories, your ideas, and what you think are the problems that need to be fixed. Because as an MP, as a parliamentary private secretary, indeed even as a singular clinician dealing, literally minute to minute, day to day, you lose sense of that wider lens. And that's why it's really important for, I think, I would say clinicians in the room to engage with people in wider industry, but most importantly for government to do the same. And I think the 10-year plan in particular is going to provide an opportunity for that. Not only at the moment where we're trying to obviously bring together all of our learnings over the last 6 months that we've had from industry, from staff, from patients, and the citizens, most importantly. But actually, once it's published, the direction that we're going to set from hospital to community, from sickness to prevention, and from particularly analog to digital, is going to provide so much opportunity for people in this room that I know feel the health service very dearly in their hearts to contribute to that process. It is going to be about taking power out of 39 Victoria Street into regions and cities and towns and into communities. And we can only do that in the modern world with the accountability and the safety that requires, with a technological spine. And I think if we're true to ourselves and reflect on the last 25 years, because of the fragmentation that's taken place in the IT developments that have been happening in the NHS, that spine hasn't been consistent and strong and reliable, particularly for partners to plug into. And I would like to see, and I'm trying my best to work with the team to make sure, as one of the results out of this 10-year plan is that we have a strong digital spine where we welcome plugins from all manner of third-party stakeholders, whether that be businesses and charities. And of course, to do that, we need to deal with the D word, data. And again, there is an appreciation right at the top of government, and this is one of the motivations, I think, for some of the reforms that we proposed in the last few months, that perhaps the flow of data, information, the way it's managed, the way it's analysed, has not been working well, both for industry, but also, most importantly, for citizens and for patients. And quite often, I found as a clinician, there seems to be a perception in certain parts of society, in certain parts of certain political circles, that patients and citizens are intrinsically distrustful of sharing their data, having their data utilised. I find it's the complete opposite. I find most of the time citizens have leapt much further forward in terms of their understanding and their expectations of what their data should be doing for them and for wider society than we could ever countenance. And things like the NHS app seems very rudimentary and basic to them. And to be honest, for my constituents in Scotland, it sounds very basic because they don't even have one yet, believe it or not, which is a separate point of frustration. So I think we've actually got to marry the expectation of the citizen and the patient with what we have now, and we need to catch up and leap forward. Of course, in other countries, which we used to call the developing world, which is now fundamentally developed, they were able to do that very easily because they could leapfrog from having no technology to a digital space. We've got to transition from lots of analog into digital. That presents its own challenges, which we need your help with. But fundamentally, it has to be done, needs to be done, should be done, and most importantly, I think I can give you confidence, will be done. And like I say, part of that, or the DNA on the nucleus of that, is making sure we get the data sharing and the connectivity right for everyone to plug in. And that kind of brings me on to my final point, which is, of course, around accountability and patient safety. Patient safety is one of those words, when I was a clinician, used to produce increasing levels of rage in the last few years. Because quite honestly, on the ground, in many organizations, it was used as an excuse to stop progress, to stop innovation, to stop people thinking differently. It was fundamentally unsafe for the patient because it was about maintaining the status quo. And that was certainly my frustration in some of the organizations that I've worked in the last 10 years. And that cannot be allowed to continue. I think, again, a bit like with the data and the digital spine, we need to move the concept of patient safety out with the simple confines of a box, of whether that be a healthcare institution or a hospital, and indeed an analog concept of patient safety into one that's something more dynamic and that's suitable for the digital world. I mean, take things like online pharmacy, for instance. This was an industry that didn't exist 15 years ago. And now, in many spheres of healthcare, it is the dominant provider of healthcare. And can we, hand on heart, sit here and say that our regulatory frameworks, our patient safety algorithms, parameters, checkpoints are suitable to that industry anymore? I don't think we can. And I think what I would like to give you a sense of is at the top of government, we get that not only is the 10-year plan or speeding up the health service and turning it around necessarily about more operations, more appointments, better patient satisfaction, but it's also about reorientating that concept of what patient safety actually means. Because what is the point of having very good patient safety within the confines of a hospital if you can't get into that hospital? What about the safety of all the patients waiting on a waiting list? Who's caring about their patient safety? So I think there needs to be that reset of the concept, and again, it needs to be underpinned with digital solutions and that accountability. You'll know we're working hard with the CQC to do some reform, and there'll be a report coming out soon that I think will have some interesting reflections for us all to consume. And I think that will be the first step in making sure that not only the NHS and the health service, but its regulatory frameworks are also match fit for the challenges of the modern 21st century. So thank you so much for having me here. It's a genuine pleasure to be here. I think I'm going to be answering some questions soon, and delighted to hear what you've got to say. Thank you so much.
The one question I've got before I come out to the audience was, I think it's very interesting when you kind of start to talk about the patient pathway and the joined-up patient pathway. There is obviously no silver bullet to do that, but how in your mind is the best way to improve that patient pathway and the data flows with the patient? How do you think that's going to happen?
I think there's two components of it. One is operational and contractual. I think there needs to be a general theme or a philosophy when we're sitting down with providers, particularly clinical colleagues, over what the expectation is of data management and data flows, particularly into the centre. So, for instance, we've done that with a GP contract recently. You'll know, and that was because that was underpinned by a philosophy and strategy in government that every negotiation that we have, every conversation that we have, we want data flows to be optimized, improved, lubricated. So I think that's one way of doing it, to have that philosophy underpinned at the centre when we negotiate. But the second part is actually more fundamental than that. It's about an attitude that we trust people with their own data. And I think, it is inconceivable that while in the rest of the world, patients get access to everything that belongs to them, we in some ways do the opposite. We make them ask piecemeal for bits of their own information. So I think it needs to be almost like a 180-degree twist to the assumptions as to what the patient should have. It should be about, it should be an exception for them not to have things rather than the other way around. So I think that attitude needs to shift, and that's more about on the ground, with GPs, with doctors, with chief executives, with information officers, that it's okay to share, because I get it. A lot of my clinician colleagues will be like, oh, well, people will ask us questions. Well, heaven forbid, if they ask you questions based on their own information. But I think it's having that, to not use a cliche, that grown-up approach with your patient.
Thank you.
Yeah.
Yeah, and one final one from me. Looking at your crystal ball, it's coming up to the end of, it's 2028, end of 28, early 2029, next general elections coming. Yep. What's the one thing that you want to achieve in healthcare?
I think
it's only us talking, so it's not going to ever get replayed back.
Again, a typical politician's answer is, I'll give you more than one thing. I think the one thing personally that I would want to look back at and view as a success is that we fundamentally changed the relationship between the NHS and technology. Okay.
Yeah, you wouldn't have thought that Ming Tang's coming on next,
right? So I think, but that needs to be the kind of proof point of that is not necessarily a statistic. It's how people on the ground interact with it. It's right?
A quality measure.
Because at the moment, if you ask a clinician about technology, it doesn't speed up their lives, it slows it down. If you ask a patient about technology, they either decry its complete absence in their healthcare journey, or again, it is about often managing their waiting or their expectation rather than giving them an answer. So I think that'd be the biggest proof point for me personally. As a government, it's obviously the targets. I think, as Wes said, we don't get to claim success as a government if the most vulnerable people in our society are still waiting in corridors and A&E departments by 2029.
There we go. Thank you. Questions, please. If you stick your hand up.
Excuse me, I'm Alan Foster. I'm a former chief executive of the Foundation Trust. Prior to that, a finance director, now retired, but working alongside the staff here in GS1. I just wanted to ask, you mentioned the 3 shifts, which was in the Darcy report, and obviously analog to digital is a big one there, which you've mentioned. What I wanted to say is we've got a 10-year plan coming, which again is expected soon. But I suppose a plea from me and a view from yourself is, in the past we've had 10-year plans. I don't think we've made a great deal of progress because the 3 shifts were part of previous 10-year plans. But I think what we need in times of financial constraints is a strategy for implementation. And rather than have 100 targets around all of these things, have some key implementation asks of the foundation trusts so that we can actually make the progress that we need in the next few years. And obviously, you've mentioned analog to digital. I would like to see Scan for Safety being a big part of that. But I wondered if you would just comment on what the expectation will be so it's clear that we can actually get some achievement right across the NHS.
Yeah. Well, thank you for that. Thank you for your own service. Listen, I share your frustrations around implementation. It's the key to get this done. That's why we're setting up a delivery unit inside the Department of Health, like Tony Blair did in 10 Downing Street itself. It's all about delivery, both for the patient, but also for political success up here. In terms of you've had previous plans in the past, I agree with you to an extent, but actually, has there been really a plan in the last decade of any meaningful sort that has had a long-term lens? I'm not sure. When I was a very young doctor, my older colleagues used to say, oh, well, these bloody governments, they come along every 5 years with a strategy and a new way of doing things. They're always changing things around. But actually, what's been most striking, I found, in the last 10 years is a complete absence of change. We've just been coasting. And now we're paying the price because the rest of the world has, travelled on ahead and we've been left behind. So the 10-year plan, in some ways, is actually just about catching up. But I agree with you on the targets. That's why one of the first things Wes did when he came to office is to slash a lot of targets, give clarity to the system. And I think Jim Mackey also is doing that now. He's giving, a great degree of clarity from the system and what we expect from the system. And that's the spirit in which we'll continue.
Thank you, Alan. Thank you, Zubir Ahmed. Thank you very
Pleasure.
much indeed.
Good to see you.
Thank you.